Hello guys, today we'll cover the basics of rheumatoid arthritis. This lecture will follow the rheumatoid arthritis chapter from Rheum Secrets by Dr. West very closely. So if you're a rheumatology fellow, you can watch this video before diving into your book as a preview, or use it as a review after reading the chapter. Either way, I hope the following slides and the information contained within them will simplify and also enrich your study experience. Throughout today's lecture, you will find slides with a fellow designation in blue at the upper left-hand corner. This implies that the slides are at the rheumatology fellows level. So if you're a medical student or even a resident watching this video, feel free to skip the details presented in those slides. Or you could keep watching, but don't stress too much about learning all the details presented on those slides. Without further ado, let's get started with our first slide. So, joint presentation of the hands. We cannot discuss rheumatoid arthritis without discussing the joint involvement of the hands. Typically, the joints will be affected symmetrically in the MCPs, PIPs, and wrists. If you see DIP involvement, rheumatoid arthritis will be lower on your differentials, and you're more likely to consider the differentials of osteoarthritis or psoriatic arthritis. Larger joints are typically affected after the small joints in rheumatoid arthritis, and patients are more likely to start with involvement of only a few small joints and then have the inclusion of multiple joints later on. So what are the common deformities of the hands in rheumatoid arthritis? I feel like all medical students know about boutonniere and swan neck deformities. I'm a huge fan of simplifying things for yourself, even when it comes to studying. And conveniently, clinical manifestations of boutonniere and swan neck deformities are the opposite of each other, so you can just remember one and forget about memorizing the other one. So if you look at the chart up here, for boutonniere, there's a flexion of the PIPs and hyperextensions of the DIPs. And for the swan neck, it's the opposite, so flexion at the DIP level and hyperextension of the PIPs and flexion contractures of the MCPs. Piano key ulnar head is a pretty impressive finding when you see it clinically. Piano key ulnar head is due to the secondary destruction of ulnar collateral ligament leading to a floating ulnar styloid head. Ulnar deviation is another deformity that can be associated with rheumatoid arthritis. Can you guess which joint destruction brings about this ulnar deviation? This may be a question you may be asked during your rheumatology rotation. And if you answer ulnar joint, I'm sorry, but that's incorrect. Ulnar deviation is actually due to subluxation of MCP joints. The name just suggests the direction of digit deformity, not necessarily the location of the actual joint deformity. And lastly, fusiform swelling refers to the synovitis of PIP joints, making the fingers appear spindle-shaped. Does rheumatoid arthritis affect joints of the feet? Yes, of course. In fact, some patients present with feet involvement first. Unlike the hand joints, it may be difficult to appreciate MTP synovitis on physical exam. So a good test during a physical exam is the MTP squeeze test, where the provider squeezes the ends of the feet with their hands and observes for tenderness. As a side note, the fifth MTP tends to be affected first in rheumatoid arthritis, which is the reason you want to pay a close attention to the areas when you're studying the x-rays. How about other foot deformities? So 1/3 of rheumatoid arthritis patients develop foot deformities during their lifetime. Have you heard of clawed toes or hammer toes? In the clinic, you will encounter patients who complain about their inability to wear regular shoes or closed-toe shoes because of these deformities. The reason for these deformities is the inflammation of the MTP joints, which leads to the subluxation of the metatarsal heads. And many patients choose to wear open-toe shoes during warmer seasons. However, when they cannot wear open-toe shoes, the tops of their toes rub against the shoes, resulting in open skin or ulcer formation. With the subluxation of metatarsal heads, the soft tissue pads that normally sit underneath the metatarsal heads get displaced, so people are walking on minimal cushion, which leads to painful walking. There are 26 bones in your foot, and they're like puzzles that fit into a functional unit that helps you walk. So if one area, like the tarsal joint or subtalar joint, gets destroyed and misaligned, it will affect your arch like dominoes and bring about hindfoot valgus deformities. It's not just the pain of our patients that we're dealing with. Rheumatoid arthritis can affect their ability to walk, jog, run, or dance. Next, let's talk about the proliferative synovium called pannus. So in rheumatoid arthritis, the inflammatory process begins primarily in the synovium, and the inflammatory cytokine milieu makes the synovial lining cells to proliferate. The end result is the inflamed synovium turning into thick, boggy, and swollen projections called pannus. Pannus can invade bone and cartilage, leading to the destruction of the joints. When you consider a tumor growing in the body, you can consider the potential destructiveness of the tumor to neighboring tissues and organs. This is what happens similarly with pannus. One important cell in the pannus is fibroblast-like synoviocyte. These cells invade cartilage and tendons. They will trigger osteoclasts, and they might even move between joints. And unlike healthy people's cells, those from rheumatoid arthritis patients can invade and damage cartilage and bone when put into mice with a weakened immune system or immunodeficient mice. Next, let's talk about symptom development patterns. So when we treat rheumatoid arthritis, we could expect to observe various symptom development patterns. About 90% of the time, patients will experience typical patterns of onset, which means they either have acute onset with severe pain, sometimes accompanied by fever, subacute onset with more systemic symptoms, or insidious symptoms that can develop over a period of several weeks to months. Insidious onset is the most common typical pattern you will encounter. But there are also variant patterns of onset that you may observe. Although these patterns might not be as common, when you encounter them, their medical history or clinical presentation is usually quite remarkable, and you will never be able to forget them. So let's start with the palindromic pattern. What is a palindrome? The word palindrome derives from Greek roots that literally mean running back. Palin means again or back, and dromos means running. Palindromes are words that read the same forward and backwards, such as mom or dad. So as the word implies, there is a symptom that keeps recurring, and that symptom is synovitis. Patients will develop single or a few joint synovitis, which will resolve within several days. After an asymptomatic period, a flare may occur in the same joint or a different joint. They can evolve into rheumatoid arthritis, unfortunately, especially if they have seropositivity or elevated ESR and CRP. Usually, these patients are treated with Plaquenil, and a joint synovitis that improves on its own in a few days, only to return later on in the same joints or different joints. Sounds a lot like that, right? Therefore, that's one of the differential diagnoses you can consider for palindromic rheumatoid arthritis. There is also something called an insidious onset of elderly pattern, which occurs in elderly patients. Pain here is most significant in limb girdle, and they will also complain of stiffness in those areas. That almost sounds like PMR, doesn't it? So that is the differential you will consider. And because this onset can present with diffuse swelling of the hands, wrists, or forearms, another differential on the list will be RS3PE or remitting SSS pitting edema or remitting seronegative symmetrical synovitis with pitting edema. Arthritis robustus is a very impressive type of rheumatoid arthritis that presents usually in men. What's unique about this type of arthritis is that during a physical exam, patients will present with a very bulky proliferative synovitis that appears severe, but they often report very few complaints themselves. Lastly, rheumatoid nodulosis is the type of rheumatoid with painful synovitis involving various joints with subacute nodules and subchondral bone cysts on x-rays. Next, we have the classification for the rheumatoid arthritis from 2010 ACR and ULR guideline. This was in comparison to the previous 1987 ACR rheumatoid arthritis classification criteria. These criteria consider 4 different classification categories: joint distribution, serology, symptom duration, and the presence of abnormal acute phase reactants. Regarding the joint distribution, higher points are assigned with more joint involvement, especially in smaller joints. For serology, having both positive rheumatoid factor and positive ACPA will earn you 3 points. A point is given for symptom duration starting from 6 weeks. An abnormal CRP or ESR will also earn you a point. A total of 6 points or higher will lead to a classification of definite rheumatoid arthritis. There are 2 requirements for target population of the previous criteria. Number 1, patients need to have at least 1 joint with definite clinical synovitis. Number 2, synovitis better not be explained by another disease. Rheumatology fellows, let me ask you a question. How many points does one need on the 2010 ACR ULR criteria to be diagnosed with rheumatoid arthritis? If you said 6 points or more, your answer is correct but also incorrect at the same time. You see, rheumatoid arthritis is a clinical diagnosis, much like in many aspects of rheumatology. What I presented on the previous slide are the classification criteria, which are not the same thing as diagnostic criteria. Just because the patient does not meet the classification criteria does not mean that they don't have rheumatoid arthritis or that you can rule it out for the patient. Let's move on to the epidemiology of rheumatoid arthritis. All races can experience rheumatoid arthritis, with a slightly higher female predominance. However, there appears to be a greater prevalence of rheumatoid arthritis in Native Americans. When does rheumatoid arthritis start to affect patients? For women, it's typically in their 40s to 60s, and for men, it's slightly older. Both genetics and the environment play roles in the pathogenesis of rheumatoid arthritis. Smoking, exposure to silica dust, and air pollution and gum disease with bacteria can all contribute. Before we delve into the details regarding the pathogenesis of rheumatoid arthritis, let me ask you another question. Have you heard of citrullonation in the context of rheumatoid arthritis pathogenesis? If you're thinking not, or if you think you haven't, you just didn't recognize. When you're looking to diagnose a patient with rheumatoid arthritis, what are the 2 most common antibodies you order? Rheumatoid factor and ACPA or anti-CCP. What is ACPA? It's anti-citrullinated protein antibodies, ACPAs. What about anti-CCPs? It's anti-cyclic citrullinated peptide antibodies. So even if you have not associated citrullination with rheumatoid arthritis, you have been ordering antibodies checking for citrullination all this time. Think of these modified citrullinated peptide as antigens the ACPA or anti-CCP will bind to, which will then activate body's immune system, which recognizes the antigen as being foreign. The activated immune response in the synovium leads to chronic inflammation and joint destruction. This citrullination can occur with smoking and other environmental risk factors listed above. So, for example, smoking can trigger PADs to be induced, leading to modification of arginine to citrulline. By the way, PADs, they stand for peptidyl-arginine deaminase, and they will citrullinate resident proteins through the post-translational modification of arginine to citrulline. In terms of genetics, rheumatoid arthritis is associated with HLA-DR genes and HLA-DRB1. You certainly want to remember it will show up a lot on your exams or while you're studying the pathogenesis of rheumatoid arthritis. Specific alleles that change the amino acid sequence of HLA-DRB1 gene were recognized, and they are DRB1 0401, 0404, 0408, 0405. There's racial associations with these alleles too. So the most common HLA-DRB1 susceptibility alleles include 0101, 0401, 0404 in individuals of European ancestry, and 0405 and 0901 in individuals of Asian ancestry. There are multiple less common alleles associated with rheumatoid arthritis, but I won't name them all here. Overall, it has been estimated that the MHC region accounts for approximately a third of the overall genetic burden of rheumatoid. You will also hear about shared epitope when discussing about rheumatoid arthritis pathogenesis. So, in 1987, Peter Gregerson and his colleagues came up with an idea called the shared epitope hypothesis to explain why some genes might be linked to rheumatoid arthritis. And they found that certain versions of a gene called HLA-DRB1 have something in common, a small part of 5 building blocks or amino acids in it. Imagine these building blocks like puzzle pieces. They might be good at fitting into specific puzzles, but when they fit, they might trigger the immune system to act in a way that harms the body. These versions of the gene are now called shared epitope. In simple words, the shared epitope hypothesis says that these gene versions might cause the immune system to be triggered in rheumatoid arthritis. In simple words, the shared epitope hypothesis says these gene versions might cause the immune system to be triggered in rheumatoid arthritis. In addition to MHC, HLA, and shared epitope, there are over 100 loci outside MHC that have been associated with development of rheumatoid arthritis. Also, many polymorphisms associated with rheumatoid arthritis are described as well. When we discuss environment factors, other environment factors are noted here, including but not limited to air pollution, inhalation of silica gel, various bacteria and viruses, and of course smoking. Smoking and other inhaled toxic agents like silica or pollution can play into rheumatoid arthritis pathogenesis as well as mucosal site bacteria and viruses. Citrullination is in the center of these triggers, as you can see in this slide. So remember the central role of citrullination in rheumatoid arthritis pathogenesis. Next, I want to mention about carbamylated proteins because it can show up on your exam from time to time. Carbamylation is another process that is associated with rheumatoid arthritis pathogenesis. Carbamylation of proteins occurs as a post-translational non-enzymatic modification where stress cells convert lysine to homocitrulline. In one study, about 30% of ACPA-negative patients with RA had detectable levels of anti-carbamylated protein antibodies. Carbamylated proteins may be associated with radiographic progression, and it's not commercially available, so its clinical relevance is limited. X-ray changes in rheumatoid arthritis will occur over several months. Early in the disease, you may just be able to see juxta-articular osteopenia, later followed by more diffuse osteopenia, and joint erosions typically occur at the margins of the smaller joints, then joint space narrowing will occur, then deformities. Speaking of erosive changes in hands and feet, in 1/3 of patients, you can observe hand X-ray changes first. Another 1/3 of patients, feet X-ray changes first, while in the last 1/3 of patients, changes occur in both the hands and the feet. Here are more detailed descriptions of X-ray findings of rheumatoid. You can use acronym ABCDESN, but without going through each letter, I just want to highlight the symmetric and marginal nature of X-ray changes for rheumatoid. Also, note that there is no ankylosis, periostitis, or osteophytes in rheumatoid. This one highlights the difference between OA and rheumatoid. In osteoarthritis, you'll see a lot of sclerosis and osteophytes and more asymmetric narrowing. And osteopenia and marginal erosions are uncommon in osteoarthritis. And cysts can occur in both osteo and rheumatoid arthritis. Oh, here's a good slide for medicine residents. When conducting a pre-op assessment for rheumatoid, obtaining a C-spine X-ray is important to identify potential instability in the cervical spine that could lead to the risk of spinal cord compression. One crucial point to remember is that you should request flexion and extension views rather than a fully erect C-spine view. While this procedure is carried out for all rheumatoid patients before surgery, particularly those who may require intubation, it's essential to note that patients with more severe erosive peripheral disease are at a higher risk of having an unstable C-spine. The peripheral joint disease can progress similarly to the disease affecting the C-spine, and significant erosive peripheral disease within the initial 5 years can indicate an increased likelihood of developing atlantoaxial subluxations. Let's review the anatomy and the names also. C1 is called the atlas, C2 is called axis. Dens or odontoid process is part of C2. So the axis. And this is the protruding bone that sits against C1, which is a ring-shaped structure. Again, the dens or the odontoid process of C2 or axis fits against the inner circle of the C1 arch. In essence, the dens is a part of C2 that touches C1. Moreover, there are apical alar transverse ligaments that hold the dens in place when it contacts the C1 arch. And this type of anatomy allows for a full range of motion in neck movement. In the case of rheumatoid, there's a synovial proliferation around the C1 and C2 articulation. So what happens? That will result in the stretching and tearing of the transverse and alar ligaments. And this disruption in the ligaments around the C1 and C2 can lead to a widening gap between the arch of C1 and the dens of C2. There are different C-spine pathology associated with the rheumatoid, but before we discuss the differential or different anatomical pathologies that can occur, let's orient ourselves first. So, the left side of the picture here, where the odontoid process abuts C1, is considered the anterior side, and the right side is the caudal side. The anterior atlanto-dens interval is measured from the posterior surface of the anterior C1 ring to the anterior surface of the odontoid process. The posterior atlanto-dens interval is measured from the posterior surface of the odontoid process to the anterior portion of the posterior C1 ring. C2 can be subluxed in different directions, so let's talk about different scenarios. When there's synovial proliferation around C1, C2 articulation, transverse and alar ligaments can have laxity, stretching, rupture, all those things leading to abnormal anterior dislocation of C2. Similar anterior dislocation of C2 can occur with erosion or fracture of dens. Posterior dislocation of C2 can also occur with fracture of dens. When there's destruction of lateral atlantoaxial joints or occipital atlantal joints, dens can actually penetrate upward into the foramen magnum. That sounds pretty bad, right? Because there's less space left for the spinal cord, and there's a potential for brainstem impingement. Patients with anterior or posterior subluxation can later obtain vertical subluxation in the future, and this has the worst prognosis due to the close proximity to the spinal cord and brainstem. Subaxial involvement can also occur when there's synovitis of facet joints and damage to the intervertebral discs and interspinous ligaments. This can lead to instability of joints below atlas and axis. This chart describes again what we discussed in earlier slides, but it gives the numbers that you need to memorize for rheumatology fellows. By definition, anterior subluxation exists if the widening gap between the arch of C1 and odontoid of C2 is greater than 3 millimeters. That is the distance between the posterior surface of the anterior C1 ring to the anterior surface of the odontoid process. Core compression risk is greatest when the anterior atlanto-odontoid interval, or the space, is equal to or greater than 9 millimeters, and posterior atlanto-odontoid interval is 14 millimeters or less. C1 to impaction. It's just another name used for superior migration of the dens. The worst neurologic prognosis expected here, especially when the odontoid is above the Raynaud's line by 5 millimeters or more. Subaxial involvement can lead to translation or subluxation of one vertebra over the lower vertebra, and clinical relevance is shown here when the translation is more than 3.5 millimeters. Leaving behind C-spine, let's discuss various studies that can be obtained in the hopes of making the right diagnosis of rheumatoid arthritis. First, starting with the synovial fluid. Residents, medical students, do you remember what test should be sent in order to diagnose rheumatoid arthritis from synovial fluid? If you can't think of any, that is because there is no specific fluid finding that will give you a definite diagnosis of rheumatoid arthritis. Despite this fact, synovial fluid findings can still serve as a helpful tool because, number one, you will confirm the inflammatory nature of the fluid, and number two, you will be able to rule out infection. Just FYI, you can have concomitant infection with rheumatoid, so just because you have infection doesn't mean rheumatoid is ruled out. I want to emphasize that point. Generally speaking, synovial fluid of white blood cell count of 2,000 is considered inflammatory. And synovial fluid of rheumatoid will have white blood cell count between 5,000 to 50,000 or even more. But again, there is no specific fluid finding on the synovial fluid that will give you a definite diagnosis of rheumatoid. Here's a list of blood tests that can be ordered for rheumatoid studies. In reality, you will be checking other labs as well, but just for the simplicity of this lecture, this is what I will discuss today. Acute phase reactants like ESR, CRP can be checked. Rheumatoid factor and ECPA can be checked. Interestingly, ANAs can actually be positive in rheumatoid, although it won't be against any specific antigens. In rheumatoid, ANCAs typically will be negative and definitely won't be against PR3 or MPO. Complements will be normal or be elevated, and if they're low, you need to consider another diagnosis. White blood cells can be abnormal with leukopenia and Felty syndrome that you could see with rheumatoid. Albumin could be low in these patients because it's a negative acute phase reactant. At times, you might actually diagnose seronegative rheumatoid. This suggests a more favorable prognosis and improved survival. Nonetheless, these patients might subsequently develop additional symptoms and manifestations that lead to an entirely different diagnosis in the future. Once you have a clinical suspicion of rheumatoid arthritis diagnosis and share the news with the patient, you will be faced with many questions. And one of the questions you might be asked is about the prognosis of their new disease. So it's a good idea to know what factors predict a poor prognosis and how the long-term prognosis is for rheumatoid. So you could guide and counsel your patients accordingly. Some of the poor prognostic factors include, but not limited to, a long duration of disease before treatment, poor functional status, extensive joint involvement, and the presence of extra-articular conditions such as nodules or vasculitis. If imaging reveals erosions within 2 years of disease onset, there's also considered a poor prognostic factor. Additionally, having positive antibodies like rheumatoid factor, ECPA, ANA, being HLA-DR4 positive, and having a low education level can contribute to a poor prognosis. Rheumatoid arthritis has evolved significantly due to the introduction of novel therapies and the continuous emergence of new treatments. Additionally, the mortality rate associated with rheumatoid is improving. Early aggressive treatment appears to be advantageous, not only in terms of enhancing survival, but also in reducing disability and the necessity for joint replacement surgery. Here's a list of factors that can increase the mortality of rheumatoid patients. I think it's important to keep these factors in mind as they can influence your overall treatment approaches as well as health maintenance and screenings. There are numerous treatment options available for rheumatoid, ranging from synthetic DMARDs, biologics, steroids, NSAIDs, PT, OT, and of course patient education and quitting smoking. An important emphasis lies in initiating treatment early, aiming to treat to a target, and adjusting therapy if low disease activity is not attained. Here's our last slide. So there are various instruments that can be used to measure disease activity in rheumatoid. There's no need to perform multiple measurements for each patient. Instead, choose one that you prefer and apply consistently during patient visits to track their disease activity. Most patients will have labs done after their clinic visit, so you won't have the most current labs available. I like to just highlight that the fact that CDI is a measurement that can be conveniently performed in the clinic without requiring the most recent lab results. Furthermore, following the visit, if you have access to CRP data, you can actually calculate SDI. Okay, let's wrap up. Today we discussed the basics of rheumatoid arthritis with some details geared towards rheumatology fellows. Rheumatology arthritis is a bread and butter case, so for medical students and residents, if you grasp the fundamentals from this lecture, I think it will make your rheumatology rotation much more enjoyable and your studies more effective. For the fellows, you'll notice that this lecture does not cover everything about rheumatoid. I believe that is an impossible job, as rheumatoid arthritis could be quite complex. In the future, I may cover various extra-articular manifestations of rheumatoid for your upcoming studies. So if you have any particular rheumatoid arthritis topic that you would like to see covered, please leave your ideas in the comment section. I hope you guys have a great time studying, and I look forward to seeing you next time. Take care, everyone.